We need you, man. Well, I think over the years we kind of started from nothing. We had two prior executive directors that were very good. Dan's done a good job. If you think we do a good job, you wouldn't mind telling them that. That'd probably a good idea because they're looking for people to rely upon that they think is worth. If we're going to get this information, taxpayers get the money's worth. And these guys going out a lot of fluff. What's the real story? Obviously. Without looking down or covering your eyes, do I really have to say this in that situation? But they started, as Ben probably told you, it's only about 10 years ago really got going. And basically, you and Cook were the people we kind of relied upon how to do things. And what we really like to do is state scene, we can say, because the first thing these guys are tell about Georgia, they'll say, we outliers, or we like these other guys. And I like to be able to say, here's the national report, here's our report. That makes sense to you?
They ranked all the states and highlighted Georgia's some of the positions.
You did?
No, I'm sorry.
I like that. Nice meeting you. You take care of yourself. Thank you.
Job security, right? Yeah. One thing you can
something left over.
Yeah, that's right. You take what you can.
That's right.
That's my motto.
That's right. Very good.
Oh, we don't need more folks now.
It's a joint one.
Yes. Okay. There's 40 folks that could be here.
She's not just a farm. Did a great job for us.
So this is your, I don't know. I should come out and see what's going on.
Yeah. Well, we have concerns with medical education and as it relates to long-term physician capacity. So it's really about national stuff also.
Never seen the regime face to face.
Okay, we have the right sizing. And then Dan wants to kind of some general 10,000-foot view things, kind of throw in the general healthcare piece and maybe some specific ideas on what to learn about it. So, I don't think specific as to this is regular.
Gotcha. Okay. I'll slide on that side. See that screen?
It's going to be perfect. I'm still going to have to help Steve. Yeah, help him.
microthroat.
Oh, that's fine.
Mike.
I'm wonderful. They know you. It's nice to see you too. I just I stuck to it when I was driving. He asked me if I knew you, and I gave him all kinds of accolades. That certainly is what he had always heard. What's his name? It's he bought Dr. Bissell practice at Douglas County. His name is Jason Bowden. Yes, absolutely. Yes. Very nice. Sharon.
Let me just see. Hi.
So she can look at me straight when I'm not there tonight.
Anything you want to come? You can speak from here. Yeah.
Great. I was
don't
just
know
going to sit at my
where
microphone.
we're actually sitting. I'm not sure if there's a table there, but since my PowerPoint slides are here, I assume I'll talk from here.
Do you have a PowerPoint copy of that PowerPoint?
Yeah.
Jim Mcnatt?
Yes, I do. It's a center within the Association of American Medical Colleges. We set up specifically.
Got jobs sometimes.
Or vice president of the Association of American Medical Colleges.
Yeah.
But
He never. He didn't get
runs the research
indefinite
center.
suspension, and he never appealed that, and he didn't. I don't know if you knew
No,
that,
that's
but he hasn't done anything. That place was ridiculous. He wanted to hire him. I know what he did.
Hi, Ed Salzberg. Washington. Bob Dickman? Oh, excuse me? Okay. Oh, yeah. Nice to meet you. Well, look forward to talking and hearing people's comments about what's going on here.
Oh, that's your thing. I was just kind of tying up with your head wires. Is this group? Are you?
I'm Ed Salzberg.
I'm Jim Mcnatt.
Hi, Jim.
I'm making a presentation later in the board.
Okay.
And is this your computer or?
No, it's
This is the group.
it's there.
It's there. Okay.
Have they loaded it?
Well, I mean, I don't know. I was just.
Who was the fellow who did it for me?
Is this your presentation?
It's my presentation, but I think the others are all loaded.
Okay, I don't even know how to do the. I have no idea. Can we just?
Yeah, this fellow was on.
Yeah, hi there, Jim Mcnatt.
Oh, nice to talk to you.
See, is it on there?
Yes, sir. We're going to have Jeremy is going to come and switch them out as the presenters will do different.
Okay.
You ready to go?
All right, good, thank you.
As long as you don't need anything not here.
Okay.
Okay. Hi. Good. How are you? I'm always happy to know that somebody got something. Yeah.
No, I don't know. Yeah, I mean, there's all sorts of stuff going on.
And what you did was actually get that. So
just as soon as the
Let me give these extras to Josh. Is that okay?
Yeah, I didn't know.
You want to put that here? Let me go see what the chairman want, okay? He said for you to keep them at the podium, and then if somebody needs them, because what's going to happen is they'll be free of folks. Here's one legislator, and I'll let you get her ready. Here's the
Ladies and gentlemen, we're about to begin. I want to ask that anyone wanting to testify before the committee that has not already signed up, please come sign up with us. Thank you.
I'd like to call this joint meeting of the House and Senate Health and Human Services Committee to order. And first, I want to thank everybody for coming today, both the legislators and our lobbyists and our speakers. I'm sorry we're starting a little bit late. It's often said that the legislature is like a big fraternity or sorority, and as you can tell from up here, many of us have not seen each other since we were adjourned at the end of March, and it's good to see familiar faces on both sides of the aisle and to welcome back committee members. And so I hope you'll forgive us this 15-minute late start. Once again, this is a great turnout from legislators on the committee. Sometimes during session, we had trouble getting this many here so we could have a quorum because of so many meetings. So I really do appreciate it. And at this point, I'm going to turn the program over to my good friend, Senator Don Thomas. So, Senator Thomas.
Thank you so much, Sharon, and let me add, I also welcome you, and I think it's great to have this number of people out. It shows a real interest in medical education and the education of physicians and other medical personnel, and our workforce studies. So we have asked Benjamin Robinson, Dr. Benjamin Robinson with the State Medical Education Board of Georgia to make our introductions today, and we certainly appreciate all our speakers and participants for having made the time to come today.
Just a minute before you start, I'm getting word from the communications people. Would you please turn off your cell phones? So if anybody has cell phones, apparently it messes up the recordings and communications. Thank you.
Thank you, Chairman Thomas. Thank you, Chairman Cooper. I'll be brief. I'm actually representing the Georgia Board for Physician Workforce today. We manage two boards, staff and I. The first presenter today is Edward Salzberg. He's the Associate Vice President and Director for the Center for Workforce Studies at the Association of American Medical Colleges. He's done work with the Council on Graduate Medical Education and did research that has been fundamental in changing opinions about future workforce capacity, and these are rather fundamental changes. Today he's going to talk about what that research shows, where they derive the research. It's all data-driven. They've put a lot of effort into this. It's very important stuff. It's really radically changed our opinion. So without any further ado, Mr. Ed Salzberg.
Thank you, Ben. Let me thank the committee for inviting me down and giving me this opportunity to speak to you today. I am an Associate Vice President at the Association of American Medical Colleges. We represent the nation's 125 medical schools, and we've been very concerned over the last few years about potential shortages of physicians. The AAMC started the center about 2.5 years ago to try and collect more data and do more studies and inform the medical education community and policymakers about what was going on and what we needed to do to better prepare the nation in terms of an adequate physician workforce. Let me say at the outset that one of the key variables here that we have to be aware of is to increase or change the number of physicians is really a 10 to 20 year effort. If you decide today that we need more physicians and you want U.S. educated physicians, then we need to add medical school capacity. That takes 2, 3, 4, 5 years. With then 4 years of medical school, 3 to 7 years of training. So what we're trying to understand is what are the needs going to be in 2015 and 2020? And we really don't want it to be that people wake up in 2015 and say, we can't get a doctor. Why can't we get a doctor? And we say, well, there's a baby boom generation who is reaching 70, and we say, well, we didn't know that. And so we really are trying to bring more information, more science to the effort to plan for the future physician workforce. What I'm going to try and present to you today very briefly is some of the overview of what the AAMC concluded as we looked at the national picture and why we're so concerned and why we recommended just 2 months ago that the nation's medical school increase enrollment by 30% over the next decade. First, let me say there is evidence already that there is a growing shortage of physicians. We know that about 1 in 5 Americans live in an area that's been designated as a physician shortage area. There have been about a dozen state-based studies over the past 5 years that express concern. We have about a dozen specialties that have done studies of the physician workforce in their specialty and concluded that they were likely to face shortages. Let me take a moment to talk about what are the key factors that are going to drive the supply and demand for physicians in the coming years. First, the population growth. People don't appreciate that this nation is growing by about 25 million every decade. And so as we sit and talk about whether we need more physicians, the population is growing rapidly. The population is aging, and I'll come back to that in a moment. I think the public has high expectations for the healthcare system and what we can do in healthcare to help preserve their life and improve their lives. We have invested a considerable amount in healthcare and medicine, and I think the public expects a return on that investment. By the way, some people could argue or raise the question of whether medical advances that are likely to occur in the next decade will reduce our need for physicians. Well, as we've looked at it, most of the advances in medicine have not reduced need, but actually encouraged the increased use of services. We are keeping people alive longer and more active, but it doesn't mean that we reduce the need for physician services. In terms of the aging, we know these numbers nationally, but it's important to bring them out. The number of those Americans over 65 will be doubling. We're talking about a tremendous increase as the baby boom generation begins to approach 60 and beyond. Why is that important? It's because we know that the major causes of illness, the major factors, conditions that lead to increased healthcare utilization, and this slide has the 11 conditions that are most costly, that almost all of these conditions, really all of these conditions, are far more common among the elderly. This is one that's particularly sensitive, age sensitive, but very, very dramatic, and this is the rate of cancer. We know that cancer is age sensitive, but when you put up the data from the U.S. cancer statistics and you look at it and you realize that, take, for example, men between the ages of 40 and 44. There are about 250 new cancers each year per 100,000 for the 40 to 44-year-old group. When you look at the 70 to 74-year-old group, you are approaching 3,000 cases per 100,000. Clearly, very clearly, the aging of the nation and the growth of the nation will lead to additional demand for services. This figure, which is a little complicated, shows the visits per person by age group, as well as the visits per person by age for 1980, 90, 2000, and 2004. Two key points here. One, older Americans make more visits to the physician than younger Americans. Again, not a surprise, but the numbers are dramatic. Under 65 Americans do about 3.3 visits per year to a physician. The over 65 is about 7 visits per person to a physician. And so as the nation increases in age, we'll have more physician visits. The other thing that this slide presents is that the number of visits per person keeps increasing for those over 45 has been increasing each year for the past 25 years at least. And so if we think about it, it's not surprising. We've invested a lot in health care, and we have more services that we can offer Americans, and they are using more services. So it's pretty dramatic when you look at a group like the 75 to 84-year-old group, which had on average only about 3.3 visits per person in 1980. In 2004, they made more than 7 visits per person. The bottom line is a variety of reasons we expect demand for physician services to be rising over the next decade. When we calculate out, if you just take the current visit rate, apply it to the population demographics in 2020, we'll expect 26% more visits. If the rate of growth of visits keeps rising as it has in the past, we'll have 53% more visits. And so for a whole variety of reasons, we see demand rising. What's happening on the supply side? A few driving key factors. First, medical school production was relatively flat for the last 25 years, and we're seeing the results of that as the physician-to-population ratio will begin to peak in the coming years. Clearly, international medical school graduates, and then the aging of the physician workforce. And let me talk a moment about that. This slide shows the age distribution of physicians. One of the things it shows is that there are 250,000 active physicians, 1 in 3, who are over the age of 55. We know this physician group will be retiring over the next 15 years. Clearly, a dramatic increase in the number of physicians over 55. That really reflects the big push in production in the 1960s and 70s. What this means, and this figure attempts to show that retirements, which are about 10 to 11,000 physicians each year in the early 2000s were retiring. We expect retirements to be about 22 to 24,000 by 2025. And so the growth, while the total number of doctors will continue to grow, the growth will not be as large as the U.S. population. I bring out this slide just to point out that the demographics of the physician workforce are changing. This is the percent female. The upper line is the percent of medical school graduates. We are now approaching 50% of new physicians are female. In terms of the actual workforce, it's about 30%. Now, I should point out that historically female physicians have worked fewer hours, slightly fewer hours, about 10 to 15% fewer hours over the course of their professional life. What we are finding, and all the reports we now get, is that the next generation of physicians, both male and female, do not have the desire of the prior generations of physicians to work those 60, 70-hour weeks. And so we expect, and we are going to be doing a study this fall, that younger physicians in their 30s and 40s, are also not working those long hours regardless of their gender. So the bottom line, this is the national perspective, is that the current level of production, physician to population ratio is expected to peak sometime between 2016 and 2021. That is the same time frame that the baby boom generation will begin to reach 70 and 75. Let me take one moment to talk about international medical school graduates. And on one hand, it's not the agenda for this group, but I think it's an important piece of the physician workforce. 1 in 4 American physicians were educated outside of the United States. 1 in 4 physicians entering the physician healthcare system today are international medical school graduates. There is concern internationally about brain drain. There is concern about the over-reliance on physicians trained outside of the country. Some of you may know that the single largest source country of international graduates is India. We know that India is developing economically. I'm not sure we can assume that we will continue to have a steady flow of physicians from India over the next 20 years. And so there is concern about this great reliance on international medical school graduates. There's also concern that a growing number of those international medical school graduates are U.S. citizens who've gone abroad, particularly to the Caribbean. Many of you know there's been a major growth in for-profit medical education in the Caribbean, targeted very specifically to Americans who want to go to medical school and have not been able to get into medical school. So we know we have citizens who want to go to medical school here. We know we will need them in the future. And again, I think it builds the case for why we recommended an increase in U.S. medical school capacity. Let me talk a moment about what's going on in terms of expansion. Allopathic medicine, the MD, the medical doctor, in 1980, in response to a series of federal reports that said there was going to be a surplus of physicians, that medical schools stopped growing. We held constant the number of medical students that were entering our medical schools. During that period, from 1980 to 2005, the U.S. population grew by some 71 million. And so the reality is we have less medical school slots now than we had in 1980. We have urged our members to increase capacity, and what we're seeing now is about a 10 to 12% increase in the pipeline. So we are encouraged that the medical schools of America are responding to the call for an increase. We ask them each year in a survey about what their plans are, and we also ask them what are the barriers that they are facing. And these are the barriers that were cited in last year's survey. 50% of the schools said the available scholarships for students were a major barrier. Clearly the cost of expansion, but limited classroom space, limited lab space, limited ambulatory preceptors, and clinical training sites were also cited as a major barrier by the medical schools of America. As I mentioned at the outset about how long it takes to increase the physician supply. It is sort of, I looked at this, and I must admit, when my staff ran these numbers, I said, could you go back and rerun them? I don't understand how, if we added 30% graduates, we increase enrollment by 30%, we're only going to end up with about 33,000 more active physicians by 2020. And the answer is, if you slowly increase medical school enrollment over the next 10 years, and it takes a medical student 4 years of medical school and 3 to 7 years of training. They're just going to start trickling out in the next 10 years. And so it's already a little late, and many people, including people like Richard Cooper, who's written extensively on this, have concluded that we are already far behind the curve in terms of production of the physician workforce. And this is the physician population ratio, which I mentioned earlier. Without an increase, would be peaking in about 2016. With a small increase, will peak at around 2021. And we think it would be far better if we went up to 30% increase, which would hold us steady at least until 2025. One comment, because people sometimes think that America is a physician-rich country. And what they usually are thinking about is, how does America compare to Canada or England? And I will tell you that the Commonwealth countries do have a relatively low physician-to-population ratio. Those are government-funded systems of care and government-controlled systems of care. What you see here is other European countries have far more. And so the United States is not a particularly physician-rich country. Yes, we spend a higher percentage of our gross domestic product on health care than others, but I would say it's not caused by the fact that we have a large number of physicians. Let me just mention overall strategies that I think we have to keep in our mind as we think about what are we going to do to assure that our citizens can gain access to health care. Again, we've recommended increased U.S. medical school enrollment and graduations. I think we have to be thinking about what can we do to keep physicians active longer. I know it's a harder concept, and sometimes people say, well, physicians are a privileged class, and why should we worry about them? We obviously have to worry about them if they're a physician in a community that has very few physicians or in a specialty that's in short supply. We have to look at how we can increase productivity and effectiveness, and there is some work going on there, and I think we have to do more. And we need to create more efficient healthcare systems and that can require fewer physicians. But I will tell you, one of my worries is people say, I think there is unnecessary services, or there are unnecessary services out there, and the Kaiser Permanente in California can get by with 25% fewer physicians, so we know we can do better. We can get by with less physicians. The reality is we have not been able to really change the American healthcare system. And I can hope that we will, but I just don't believe that we're going to be successful over the next decade in seriously reducing the demand for services. And I do think the aging and growth would overwhelm even those improvements in efficiencies. And then finally, we could increase the number of international medical school graduates. And as I said, that's not a desirable strategy, but I worry that if we don't do more to increase our physician supply, 2010, 2012, 2015 rolls around and our citizens can't get services, I don't think we're going to be like the citizens of England or Canada and say, okay, we'll wait 6 months, we'll wait a year to see a specialist or get a surgery. And so I think there would be pressure on America to recruit more physicians from overseas, and I'd rather not see us put ourselves in that position. The AAMC has recommended a number of actions to try and address the physician workforce needs for the future. I mentioned we've recommended that 30% increase in U.S. medical school enrollment, and that we felt needs to be done in part through the expansion of existing schools, but we recognize that in some parts of the country there is a need for some new schools as well. We've recommended an expansion in graduate medical education funding as well. Let me be clear, and I know this has come up here in Georgia, that I recognize that medical education is only the first part of a two-part process, that physicians, to be licensed, to be fully educated and prepared, have to go through graduate medical education. So just increasing the first step is not sufficient to produce an increase in supply. As many of you know, Medicare, federally funded Medicare program, is the major source of financing for graduate medical education. There has been a cap on graduate Medicare funding since 1997, and that has significantly slowed the growth of graduate medical education training. And we are concerned that if we ask and our medical schools respond to the need and the call for an expansion, that if you don't increase graduate medical education, at least in parallel, that we won't produce the new physicians needed to serve Americans. We recommend needing specialty choice up to students, residents, and teaching hospitals, but they need more information. On that, let me make a positive comment about the work being done here in Georgia. We've tried to be, at a national level, data-driven and collect and analyze the data, and I think Georgia has really done a fine job. I spent a lot of time going across the country talking to folks in states, and I think the data being collected here and the analysis being done here puts you in a really good position to better understand what's happening in Georgia. And so, again, we encourage better information to inform decisions by students in medical schools and teaching hospitals. We've also recommended an expansion of the National Health Service Corps, which is really the major source of funding for students that want to go into underserved area. And you know, most of you know, student debt has been a growing issue of concern, that students are now graduating on average with more than $100,000 of debt. Many of the students are well beyond that, and we're concerned that that will not allow them to choose specialties in areas of practice that are in need. So anyway, we do recommend an expansion of the National Health Service Corps. We think it's critical that we continue efforts to expand the diversity of the physician workforce. This has been a goal of the association for many years, and clearly far more needs to be done. And finally, we believe that you need to continue to monitor and study the physician supply and distribution, because no matter how good my estimates are, how much we work at trying to forecast the future, there are just many things we just don't know. And so continually collecting and analyzing data and adjusting your position is needed. And one closing comment, and I know that Ben will talk more about the situation in Georgia. As I looked at the data on Georgia, and I do have a piece that I handed out and have more copies, which is called Key Physician Data by State with the Georgia highlighted, which is a piece we put together to help states understand how they compare to other states. And it's a relatively simple, straightforward, and Ben probably has more exact figures for Georgia, but I wanted to show how each state compares on a variety of indicators. And so Georgia is 38th among the 50 states in their physician-to-population ratio. In terms of medical school capacity, we count them as 35th of the 50 states. And in terms of graduate medical education, 35th among the 50 states. And so as I look from the national perspective, I think there's more that Georgia probably can do to produce more physicians. I will tell you that one of the problems, the sort of historical evolution, is in 1980, when we thought there was going to be a surplus, and that was reasonable for 1980, U.S. medical education capacity stopped growing in 1980. We now recognize that we need to ramp up, but states that grew significantly in the last 25 years are among the states that are the low end of these ratios. And so I think I'm not surprised to see a lot of interest in the South and the West regarding expansion of medical school capacity and graduate medical education, because we stopped growing in 1980. So let me stop there, and I don't know if the chair would like opportunity for questions or comments.
We're a little short on time, but we could entertain one or two if somebody has a pressing question.
Okay. Representative Mosby.
How you doing? Great presentation. Listen, the cap on the number of residents that residency training programs can have in, how is that affecting the number of residents that are coming on the scene?
There has been a slight growth in the number of residency positions nationally. When Congress basically capped Medicare, there were about 97,000 residents in training in ACG and allopathic programs. There's now about 105,000. So over the last 8 years, there has been some increase. Most of that has been funded by the individual teaching hospital who makes that decision about whether to add capacity. One of the concerns that I have would be that if you totally rely on the individual hospital to make an individual decision about whether to add a residency program in the absence of funding, I worry that their decision-making will be influenced by which specialties are going to bring more money into the hospital and less likely to add a specialty that may be needed but may not do very much for the hospital. And I'm not saying that's what they're doing, but I think in the long run, relying on sort of the voluntary decisions and the goodness of the intentions of teaching hospitals alone is probably not sufficient.
Senator Hampson.
Appreciate it. Just where we are now, kind of how did we get here? In other words, was there artificial shortage? Did the medical community say, kind of keep doctors low to rate prices? Were people afraid to get into the medical because of the cost of going to school? Or was, managed care and the type of health system we have, period, to blame? How did we get to and why are we where we are?
I think there are two reasons. The first is the work done in the late 1970s, early 1980s, was really concerned that we were, at that point, growing too fast. We literally doubled the number of medical students in about 15 years because there was a federal capitation incentive program. And if we had kept growing at that rate, they thought we would have a surplus. In the 1990s, which is when I think we would have normally said, hey, wait a second, we're planning for a different era now. Managed care came in the early 90s. And everyone said, well, tightly controlled managed care is going to look like the Kaiser system. We're not going to need all those doctors. And so that really dampened any enthusiasm or motivation or effort to build support for an expansion until really the to the early 2000s. And we are now seeing this change, and people are saying, that we're not looking at how many doctors we need in 2000. We're now looking at how many doctors do we need in 2020, and so the picture has changed. Maybe I'm covering for the poor job of workforce planning we did in the past. Again, forecasting is very difficult, and that's why I want it to be as data-driven as possible.
Just follow up. When you say we thought the need in the 1990s, we didn't think the need would be there. So who was controlling the access? The medical field itself or government? Did they not see the need, or hospitals, or
Yeah, it was the we. That was a collective we of the medical education community. 2/3 of the medical schools in the nation are state supported. You just couldn't go to a state legislature and say we need another medical school when you have reports coming out saying there's going to be a surplus of physicians. And so now that, again, the times are changing, the researchers are concluding that we're going to have more needs, and we are seeing discussions. I mean, whether you look at Florida or Texas, a whole variety of states are saying we've grown in the last 25 years. What do we need to do to assure an adequate physician workforce?
One more question from Representative Cooper.
Are there studies available that would indicate a correlation between where a physician does his residency or his advanced medical training and where he chooses to live after that training is completed?
Yes. And in the set of tables, and I'll make sure, I think I have copies here so that everyone can have a copy. There's a figure, figure 7, which is retention of residents and fellows in state. And the national average is 47% of the physicians. When we look back and said, physicians are practicing in the state, of those who went did their training in the state, how many are still in the state? The answer was 47. The figure after, which is on medical school, that is 39%. So yes, residency training has a greater impact on where a physician locates than where they do their medical school education. I will tell you that if a physician does medical school and residency training in the state, you significantly increase the likelihood that that physician is going to stay in the state. It goes up to about 65%. So yes, if you're a state saying, how can we get physicians in our state, then having medical education and graduate medical education really is an important part of the picture.
Mr. Salzberg, thank you very much for your presentation. You have also lessened my guilt over the fact that my 71-year-old husband, who is an MD and family practitioner, is still practicing. So I'll try to encourage him so we'll have less people that are leaving the workforce. So.
Thank you very much. Appreciate the opportunity.
And I'm 73 and still going.
I didn't want to say anything.
And we have Dr. Ben Robinson now.
I think
medical education.
because he's working.
There we go, sir. Great, thank you.
Thank you again, chairman, for the opportunity. My name is Ben Robinson. I am the director of the Georgia Board for Physician Workforce. I've been here about 3 years. And the Georgia Board, of course, has been here about 30 years now. I've been studying in various shapes or forms, but studying physician capacity for quite some time. What I'm going to do today is show some specific issues to Georgia that reflect what Mr. Salzberg was just talking about. And then speak about what we need to do or some challenges our medical education system confronts as it looks into 20 and 30 years down the road and making sure we have the physicians we need. First of all, and I think this will come as no surprise, Georgia is a fast-growing population. That's one of the fastest in the country. During the 1990s, we added 1.7 million. In this half of this decade, since 2000, we've added almost 900,000, and we currently have about 9.1 million. We're now the 9th most populous state in the country. The census estimates that over the next 30 years, we're going to add roughly 4 million additional residents to the state. That's when you add that to what our population used to be, that's about a 100% increase from 1990 figures. Not only that, and I'll be quick here, the population is aging. Again, I think no surprise here. We've been hearing this for a while, but I think the extent of the aging is quite alarming. We are currently younger than most states, but we are growing rapidly. 65 plus is going to grow by 1.1 million in the next 25 years. If you look at these tables here, currently it's less than 10% of the population. It will be over almost 16% of the population by 2030. And as Mr. Salzberg was showing, the older populations demand greater access and services from the healthcare system than the younger ones. So we should anticipate, not only based on the growth in our population, we should not only anticipate a regular increase in demand, but we should an exceptional increase in demand as the population grows and ages. So that means we need to begin looking at what the current physician capacity is. And another thing that Mr. Salzberg was talking about is even as the demand is growing, the average output of physicians is expected to decline, and our own current workforce has some challenges. Let me state, first of all, that these are long-term concerns mostly. We do see some challenges today, but they pale compared to the challenges 10, 15 years down the road if we don't do anything about it. Specifically, what are these? Good news, we've seen the physician population in the state, after stagnating for years, since about 1996, it was at 192 per capita per 100,000. In 2004, we finally saw a growth in that. It grew by about 8 or 9 per 100,000, third highest in our recorded history. And that was because we actually added a lot of physicians in the last renewal cycle. We added a little over 1,000, which is about a 6% increase. That is unusual, as you can see in this slide. We've had a couple spikes, but usually we're pretty low, around the 700 per every other year level. Now, having said that, that's certainly good news. There are still challenges. Currently, Georgia ranks 37th. Now, Mr. Salzberg just said 38th. He's dealing with 2 years. His data is newer than ours. We're just counting our 2006 now. It'll be a while before we get it out. But as of 2004, we were 37th in the nation. And we were 38th 2 years before that, in 2002. We've traditionally hovered in the low to mid-30s. And so that obviously has implications for access and particularly long-term growth. And if we're going to maintain capacity long-term, we have to understand we're not necessarily starting from the best starting point. Now, having said this, there are some long-term trends we're concerned about. And these reflect what Mr. Salzberg was saying. The X and Y generation physicians are increasing in numbers. The new generation of physicians with that introduces different perspectives on work. And this suggests potential concerns with reduction per capita or average reduction of work effort by physicians over the time. This slide, the interesting thing I want to say, one, you see the aging of the population. You can see two things. One, the mode or the greatest number of physicians in 1992 were in 35 to 90 age range. In 2004, that has switched about a decade to 45 to 49. So we see an aging of the workforce. That suggests retirement might also be a problem in the future, which is something that Mr. Salzberg was talking about. We are just beginning to collect data on that. We introduced questions on that with our most recent renewal survey. So we don't have specifics on Georgia, but we anticipate that could be a problem. You also can see that the percentage of physicians less than 35 is beginning to climb as well. That's good news, but it introduces the concern with the X and Y generation work characteristics increasingly entering the workforce. They tend to work fewer hours for very good reasons, and there's no changing that, we don't think. But we have to anticipate an average decline in work effort by physicians in future years. One last thing with average physician capacity, and I apologize for this, I hit a wrong button when I put this together. The growth of women, the percentage of women in the workforce is also growing. And the concern here is that over a lifetime and due to very understandable issues of life cycle, women still can have or bear the brunt of family and life responsibilities. They will work fewer hours, and we are seeing the percentage of women grow in medicine. It's kind of hovering around 20% right now. It's been hovering there about past 4 years. That will increase because when you look at enrollment figures at the national state level, at the national level, 49% of matriculants to medical school this year were women. So we anticipate that to increase. I'm going to speed up the next few slides.
Ever seen Mrs. Joyner, you're making the lights go up and down. You're so electric.
Even as these concerns emerge, we see some current ones right now. One, it's small at this point, but we figure it's very important. It has to do with primary care and core specialty capacity. Since we've been keeping records, we've seen a steady growth in the percentage of physicians that report to be pediatricians, family physicians, general internists, OBGYNs, and also general surgery. For the first time since we've been keeping data, we've seen a reduction in the proportion of physicians that report to be those specialties. That is, again, very small at this point, not a concern yet, but if it continues to grow, it will be a problem in the future. Just some figures on where our trends are with specialties. Diagnostic radiology and gastroenterology, we predict they will be in shortage if their current growth trends continue by 2010. So that's why those are highlighted in red. The big one here is general surgery, actually, which has fewer per capita today than it did 12 years ago. And this is the case even as Georgia struggles with its trauma capacity. There are some other issues there, but those are kind of the highlights. And the last thing I wanted to stress was distribution. This slide here shows a comparison between urban and non-urban. MSA is an urban, it's a metropolitan statistical area. The non-MSA is the rural. If you look at pediatrics, for example, it's a 5-to-1 difference in capacity of physicians between urban and rural. There's about 3.2 per capita compared to 15.1 in urban areas. So that's a concern. A current one, and obviously as we begin to struggle more with physician capacity, those could easily grow. This just shows how they're distributed over the state in our primary service areas. 50% of pediatric primary service areas are in deficit. That's a 5-0. So people who are looking for help caring for their children might have difficulty in certain areas. Yes, family physicians and general internists can help with some of that, but you sometimes want the physicians best trained to deal with particularly unusual or very problematic cases. OBGYNs, 40%, not as stark, but family physicians and general internists can do this as well, at least the obstetrics part, but that's declining as more and more, and fewer family physicians are opting to get the obstetrics background and to do obstetrical work. That's where the current physician workforce is right now. What I want to turn to now is what does that mean for our physician capacity or our medical education system. What this suggests is that we have to look long-term to make sure our medical education system is up to speed to do what it needs to do. And as Mr. Salzberg was saying, the capacity of the system has historically been less than what it needs to be, or less than what it's been in other states. We currently rank 35th in the country. We've hovered around 34th, 35th for a number of years. And our per capita enrollment for both medical students and residents is below the national averages. There has been some growth in some of these outputs, but it's only been recent. There was no growth in the 1990s, and the recent growth in medical schools in particular has been very recent, and we have yet to see their outputs. Medical education, I want to kind of walk us through. I'll be quick here, but what it consists of, and so that this body can understand how the state has tackled medical education. It's unique to some of the other states. Undergraduate medical education, which I'll call UME from this point on, is provided by the medical schools. It's the training that students get during their 4 years of medical school to give them the basic science education they need. It's done through didactic classwork where you sit in front of a lecturer and they tell you things about science and anatomy. It also is done through clinical rotations in the 3rd and 4th year where they actually begin to be exposed to the specialties and how medicine is actually delivered. Georgia, with its UME, is very reliant on private medical schools. Now, this was a conscious decision this body made years ago. The idea here is to capitalize on the resources that the private medical schools already have. And it takes about $90 million to run a medical school, but we spend currently about $33 million to bolster the support of the private schools in this system. We have one public medical school, that's the Medical College of Georgia. We have currently 4 private schools. We had an increase this year, and they currently train over 50% of our students. One thing we do with these, we put stipulations in contracts. One, primary care. We try to get at least 50% of our graduates going into primary care residencies, and on certain occasions we require that they fill a certain number of slots in the private schools with students from Georgia. What are the impacts? Quality UME provides a sound basis of knowledge. You can't practice medicine without it, so you need the UME side as well. Provides an opportunity to influence needed outcomes, and there are a couple here. Again, the primary care. As Mr. Salzberg was saying, medical schools themselves are not a predictor of practice location, but putting students from Georgia are. Students, through personal affinity, will gravitate back to things they're familiar with, either their hometown or home area, or rural versus urban, those kinds of things. So it offers an opportunity for us to encourage physicians to remain in Georgia and also go into underserved and rural areas. And through that, of course, it maximizes the state's return on investment. We've been very successful. One thing Mr. Salzberg didn't say, but it's in the material he provided, Georgia has the 11th best retention of medical school graduates in the country right now. So we are quite well off there. Just a couple things we've succeeded. These maps show where graduates from our 2 biggest beneficiaries go. Mercer has a 65% retention rate in-state once they finish their residency. Mercer has a rural focus as well, so they distribute very well throughout the state. Morehouse has about a 50% retention rate. That's above average. And they have a more of an underserved focus. They tend to, a lot of them go to urban Atlanta, and there are many areas of need in urban Atlanta. There have been some recent changes, and this kind of gets us into some of the concerns we see. We had a new medical school open in Sewanee last year. It sat its first class. This is the Philadelphia College of Osteopathic Medicine, Georgia campus. It's an osteopathic school. It sat its first class last year. 84 students moved to the second year. They have sat their second class. I don't know what the current capacity of that is, but it's around the same level. When they're fully filled, they will have, they estimate, 400 students being taught. We've seen some increase in enrollment ongoing in our existing medical schools. We have a 6th medical school being considered down in Savannah. And the total enhancement we anticipate from what's happened already is about 25%, and that's very conservative. But with the 6th medical school, it'll probably begin to range 35 to 40%, if not higher. So our UME capacity is certainly meeting the call that the AAMC has called for with 30%. Now, there are some challenges we see. Because there's been an increase in the cost of medical education in the past 20 years. Private schools, it's gone off about 160, 165%. Public schools, it's gone up about 300%. Now, the difference there is because the cost of public school was lower to begin with. So it's not as stark a rise as it seems, but it's nonetheless very substantial. There have been times recently in this state where there have been double-digit percentage-wise increases in tuition in this state. That was particularly the case 2004, 2005. And given Georgia's dependence on private medical school, education costs are likely larger in Georgia than they are elsewhere. And so this is something we need to think about when we're moving forward. These are some costs for medical education as of last academic year. Just to kind of show you what students have to pay to go to medical school. This is not counting things like transportation, room and board, fees, those kinds of economic costs students have to encounter. Very important is the medical education debt we see. Students are leaving residency with remarkable education debts. And this is important because it impacts what specialties they're going to go into. It impacts where they're going to practice. And in some cases, it can also impact interest in medicine in the first place. We've seen a remarkable increase over the past few years. Currently, 50% of students have debt in excess of $80,000, 42% in excess of $100,000, and 8%, almost 1 in 10, have debt in excess of $200,000. Those are remarkable amounts. Another challenge is clinical rotations. These are required in the third and fourth year. They are important in ensuring physicians begin to see not only the science of medicine, but the art of the science, begin to apply it on a day-to-day basis. They require access to clinical sites, hospitals, doctors' offices, whatnot. With the addition of the medical schools, that's going to be a potential concern. We don't know that we're heading off a cliff at this point, but it's something we need to be very mindful of so that we don't begin to build bottlenecks or, more importantly, begin to build clinical rotation sites out of state, which begins to funnel our investment out of state as well. Next is graduate medical education, GME. This is provided by the teaching hospitals and the residency programs. It's what enables physicians to specialize. It gives them very unique training so that they know certain body systems, certain disease states, whatnot, and gives them the expertise to do quality medicine on a regular basis within the community. Our primary focus in this state has been primary care. Family practice, we currently support, this is the Georgia Board and the state through the Georgia Board, support 202 positions for family medicine. We support 43 slots for pediatrics. We also support 10 preventive medicine slots. Those are important because that's kind of family medicine at the community level. So we think that's a very important thing to do. And we also, through one of our programs, cover the positions or residency slots in teaching hospitals and hospital authorities, and that covers every specialty. Residency training programs are also under contract. 50% of them need to stay in Georgia to practice once they're done. Impacts, again, this gives them the capacity and the training to specialize and provide very, very high-skilled medicine on particular areas of concern. Residency location is also the single biggest predictor of practice location. And through these, we can not only say, if you're in Georgia, there's a better chance you're going to practice here. We have some rural residency programs, and through that we also acclimate students to practice in rural parts of the state. And again, this is another way for us to maximize the state's return on investment. Again, we've been very successful. All programs supported by the board must retain at least 50%. We've had a couple things in the past where we weren't, but those have been taken care of, and our programs continue to be successful in that area. And the AAMC also reports that Georgia has the 14th best retention of GME graduates in the country. So we think it's working. This is just some specifics. 74% of our graduates in FP, that's family physicians, are retained over 5 years in state, 64% of pediatricians. These are, again, not all the slots, and some specialties are covered, but the ones that are covered, this is what we're doing. 64% in pediatrics, 68% in preventive medicine, and 62% in general residency programs covered by the board. There have been some changes to GME, but they're not as large by any stretch as what we're going to see in the undergraduate side. There has been some expansion, about 12% or so, since 2000, and this has been due to expansion of existing programs. There has not been a new hospital stepping up and saying we're going to run a residency program. I believe some are considering it, but nobody stepped up to the plate at this point. And so this growth is far lower than it's been seen in UME. And this is a big challenge because as Mr. Salzberg correctly stated, we share his philosophy. What you want to do is get Georgia students into programs here because they're already more predisposed to come back to Georgia. Ensure they can go to residency in the state if they choose to. And that way, again, as Mr. Salzberg's saying, we're going to get a good return on our buck. And so that's the concern we see there. More specifically, some challenges. There actually has been some minimal reduction in primary care capacity. We lost a couple slots in OBGYN collectively over the past couple years. Family medicine, we lost 3. That's going to grow, actually. One of our programs is reducing its support of family medicine. Preventive medicine, we lost a few slots as well. And there's some other reductions ongoing elsewhere. Now, yes, our overall number of slots have increased. Let me be clear, that's because there's been a shift in some hospitals away from primary care. We do need subspecialists, but we also need to make sure we keep our focus on primary care. Declines are minimal, but must be watched over time. So specifics, Medicaid managed care, this is cautionary. We don't know that there's any concerns with this at this point, and we all know because of the growth, the rapid growth, if not uncontrolled growth in Medicaid costs, we have placed our Medicaid system under managed care. We are watching carefully. We did receive some assurances from the Department of Community Health that they were taking steps to ensure that there was no undue financial hardship that Grady Hospital and the other teaching hospitals had to bear because of this change, but it's something that warrants scrutiny because we don't know ultimately how it's going to. I've been told a lot. It's so new. It's been in place about 2 months. We don't know ultimately what it's going to do. We caution this body, the Department of Community Health, and we'll continue to watch it ourselves, to be mindful of that. Medicare is very important, and Mr. Salzberg was talking about that. The problems here, there was a cap put on Medicaid slots that are funded by the federal government, Medicare. That was placed on Medicare budget in 1997 through the Balanced Budget Act. There have been some tweakings of that to kind of adjust cost structure and whatnot, the most significant of which was the Medicare Modernization Act of 2005. It didn't fundamentally change anything. The caps on Medicare investment on slots are the same. What they did in 2005 is allowed individual programs to request some moving of slots around. There were about 3,000 unfilled slots, and they've allowed those to move around. Georgia did get some, but we are still trying to figure out the exact number of that and where it's going to lead us. However, it will not solve our overall capacity problems. Last but not least, the financial health of Grady. This is important because most of us, if not all of us, understand Grady is a critically important hospital in terms of trauma care and direct provision of health care. It, however, is also the single largest site where our residents get trained. About 1/4 of our residents train there. And through that, every single community in the state, they are providing the physicians for all of Georgia through that. It's something I don't know is as well known as it should be. One of the things I wanted to do here today was make sure that was understood. And Grady, of course, continues to struggle. We don't know what's going to happen with the CMO and what that's going to do. And one very related thing, and this has to do with the upper payment limit, and I didn't put it here. I wanted to kind of touch base with some folks before I did, but I'm going to go into it now. It has to do with Morehouse. The federal government has been clamping down on upper payment limit and how states use that. And, of course, Grady and other cuts through Medicaid and Medicare have made things very tough on Grady. It has, at this point, having to retain its UPL. Historically, it has allowed Morehouse to use that for matching our dollars, the Georgia Board dollars that are given to it through the operating grants. Were matched with Medicaid dollars, about 60-40. And this is understandable. We do not hold Grady at fault here. Its solvency is critical, too. It is saying it has to keep the money to maintain its own solvency. That will leave Morehouse in substantial financial hardship. And we want to encourage this body to look at Morehouse. Morehouse is a critically important institution. We actually have gone through this process with Mercer many years ago, and we kept Mercer whole. And Mercer continues to do an excellent job for the state. But we need to begin looking at Morehouse and listening to them and hearing from them as we move into the future. Just some final points. Again, I want to assure everybody or reiterate sharp increases of demand are expected. We have concerns now, but it's in the future that the big concerns are going to come. We have to make sure the workforce expands appropriately. both understanding the reduction in average work effort and the increasing demand we're going to expect. The best response to this, historically, Georgia is often an importer state of physicians. That leaves us vulnerable to what other states do. If they decide they're going to take great efforts to keep their physicians in state, we're going to be paying the cost for that. The best response is to make sure our medical education system is sufficiently is of sufficient size and capacity to meet the needs of the state. That means we need to make sure our third and fourth year rotations are right. Our UME numbers are expanding to the right level. We maintain our focus on primary care, and we make sure we have a comparable growth in GME as with UME. And I think ultimately we explore ways to address and account for funding constraints on this system. Unless there are any questions, that's my presentation.
We'll move right along, but I believe Senator Balfour, Chairman of Rules, has a question.
Yes, sir.
I want to ask two just very quickly. One is you talk about the increase in demand, the decrease in the amount of hours that a doctor's working. I didn't hear any reference between either one of you two gentlemen about the change in the way medicine is working. I mean, when I was growing up, I saw the doctor every time I went to the office. My son's 19. I can count on one hand the amount of times he saw the pediatrician. He's seeing an advanced nurse practitioner. He's seeing a PA. But you didn't. Neither one of you addressed. There is an increase in demand. I'm not going to argue that. But there are other people also seeing those people.
I think you raise a very valid point. Unfortunately, we don't have data. Our statute is specific to physician workforce. There was a body, and of course, Dr. Ron here will speak to some of the stuff that the Board of Regents has done, which will look at that issue. We don't have data specific to the advanced practice nurses and the physician assistants, though.
Well, then it's hard to figure out what the need for supply on the side is if you're not looking at the total demand.
I would agree, sir, that there was, in fact, a committee working with the Department of Community Health. I staffed that committee years ago that was looking at the non-physician workforce. It's no longer in place, and I think the Board of Regents is beginning to step up to the plate in that regard. We do need to look at that. It's just not being done right now.
Okay, let's go on. You want to introduce Dr. Ron? Yes.
Senator Unterman has one more.
One more question, then Senator Unterman.
My question is sort of related to, is this on? No? My question is sort of related to Senator Balfour. When you're doing these statistics and you're showing where the physicians are, you're not showing exactly what they do, because some of them you may have a surplus in some areas, but if they have closed practices and they're limiting who they're seeing, it doesn't matter how many physicians are in that area or not in that area if they won't see all patients. And we're seeing more and more physicians who are closing their doors and only seeing insurance patients or limited number of patients. So what good are these statistics?
Well, we've begun. They're still because we can compare them to what other states are doing, it gives us a good ballpark. We do have some understanding of where we need to be heading. In terms of these standards say we need to be within this range of family physicians and whatnot. The challenge there is, as Mr. Salzberg was saying earlier, the understanding, the concerns have changed. There's been this big awakening that as these older Americans move in and advance in age, that changes are taking place. And as the newer physicians walk into practice, changes are taking place there. So we need to look long term. And absolutely, one thing we generally don't do is say we need to be right here with our physicians, because if you do that, you're going to get it wrong. Changes happen. I understand what you're saying.
And what my concern is that they're not seeing Medicaid and they're not seeing Medicare. And also, we're training these physicians, like if they go to school in Macon, then they go out into private practice, well, they won't see indigent patients. So what good does it do for the state to educate and fund part of the education if they go into practice and they're only seeing the rich folks?
There are certainly issues with that. I think there's a wider range of factors that contribute to your concern. I don't know if that's the medical education system itself as opposed to how we fund as a state and otherwise services that physicians provide. We have refined how we calculate acceptance of Medicaid. We did this last year. We wanted to know more, are you taking new Medicaid patients? We actually have historically calculated how many people accept Medicaid. We don't think that's sensitive enough because 80% of folks do, because if they have 1 or 2 patients, they'll see them if they've had them for 20 years. So we're trying to refine that. We do think your concern is very valid, that, and we are listening to what the physician community is saying about the changes we're making in our Medicaid reimbursement, see what that's going to do. Thank you.
Hi, I'm Dan Ron. Thank you, Ben.
Oh, sure.
I know most of you, but I'm the president of the Medical College of Georgia, and I've recently been appointed to a new position at the university system level as Senior Vice Chancellor for Health and Medical Programs for the university system. And I've been asked to really kind of reflect, I guess. So I'm going to only talk for about 10 minutes, and I have handed out a brochure which I would ask you not to look at. Let me just begin with one fact. Through a recent study done by the United Health Foundation, Georgia was found to rank 43rd nationally across a broad range of indices of health of the population, most of which are treatable or reversible. Issues like low birth weight infants, perinatal mortality, infectious disease burden, premature mortality from cardiac disease or cancer. So somewhere, somehow, we're not doing the job that we could do in meeting the broadly defined health needs of the population. The Medical College of Georgia, if I can, for just a moment to talk a little bit about your public institution, has 5 schools: nursing, dentistry, allied health sciences, medicine, and graduate studies. We have 2,100 students, about 500 residents. In the School of Medicine specifically, 98% of the students are residents of Georgia. To the extent that we know it, of those individuals who are licensed and practicing, close to 2/3 of our graduates who are in practice in Georgia. Because of the state support that you provide, you've seen the tuition differential that Ben showed. It's not because it's less expensive at MCG. The difference is what it is that's provided per student through the state appropriation. For that reason, they graduate with lower debt. Half of our students, I don't know the 2006 data, but for the year that I know most recently, half of our students have $30,000 or less in total indebtedness when they graduate. That's a big impact in terms of career choice that one can make. Additionally, to reflect on one question asked earlier by Mr. Mosby, our teaching hospital, the Medical College of Georgia Hospital, is currently 16 positions over the cap. So for our residency positions, that means that of the 500, for 16 of them, there is no reimbursement, there's no capturing of any federal dollars through Medicare or any state funds through Medicaid programs that are there specifically to support higher education in medicine. That is an issue as the financial operating environment for hospitals becomes more challenging. That's an issue as to who's going to pay for that. We increased our class size from 180 per year, 720 total students, to 190 per year this year. In order to do that, it doesn't sound like a whole lot. We had to revamp the main large teaching classroom. Now, it needed to be wired so that everybody would have internet access, and we needed to replace seats. It was $1 million. It was $1 million to replace 2 classrooms just with interior work. The expenses associated with the changes and the ramping up are significant, and you probably know through the funding formula, there will be some additional funds to the university system 3 years from now, but not now. Because it's based upon the most recently completed year, those data going into the next year's budget. So we're fronting that right now out of our operating budget, and we thank you for the support that you provide. I'd like to just summarize for one moment some of the things that Ed said. that with a 10-year time horizon, we can expect that there will be a significant physician shortage, and that the shortage will tend, our maximum capacity will tend to peak at about the time when people my age are beginning to move through the baby boomer system. And I thank you for looking to the future. I have a quote here from Charles Kettering. Charles Kettering was an American inventor who, among other things, invented the electric starter for automobiles. He said he likes to focus on the future because he plans to spend the rest of his life there. So I thank you for focusing on the future. So we really are we're looking out 10 years, but changes made today won't have any impact on practicing physician workforce for at least 10 years. So it is time to be doing that. With that kind of time horizon, the recommendation of our leadership in academic medicine nationally is to increase the number of American medical school students by 30%, ramping up over a period of 10 years, and to match that with increase in the GME capacity. Can't overemphasize the importance of looking at both components. Medical student graduation rates alone have no impact on the number of new license-eligible physicians each year. That is determined entirely by individuals who have completed residency training. So you must have a GME strategy as well. The drivers of this are aging of the population growth, changing expectations of the population, medical advances, increasing the capacity of what we can do. I graduated from medical school in 1976. There is no condition that I'm aware of that's treated the way it was when I graduated from medical school, not even a strep throat. So, our changing expectations, changing capabilities, and also the conversion from acute to chronic illness really changes the way in which we need resources within the system. And then there are changing expectations of physicians themselves, based upon what their expectation is from their profession and their commitment to their profession, gender differences, projected retirement ages. I would speculate that most of our current under 40 physicians are not planning to work until they're 71 or 73. And so that's an issue as well. Now, I have little wisdom to add to what Ed and Ben have spoken to here this afternoon. I had the privilege recently of chairing a task force for the university system. I didn't produce slides on this, but I have all of the data. I've given you each a 68-page report of our final report provided to the Board of Regents. I can summarize that by saying that we were charged to review the university system's current health professional program array and capacity, looking across all disciplines, not just physicians, but looking at allied health, nursing, pharmacy, mental health professionals, dentistry, the whole array of health professional programs, to assess projected workforce need by discipline, to analyze gaps, and to make recommendations. And to summarize our findings, we found that there is no discipline, no practicing health professional discipline in which Georgia as a state reaches the national mean adjusted for population. We have shortages currently that are broad and deep and rather pervasive. There are many different explanations for why that is. Perhaps the best known is nursing. Our understanding, to the best that we understand it, is that we are short about 900 nurses, right? 9,000 nurses in comparison with current demand. And unless there are some significant changes, the gap between supply and demand will grow to 20,000 by 2012. That's in a national context where the expectation, the understanding is by the year 2015, there will be a gap of close to 500,000 nurses between the demand and the supply. So nursing is very well known, but the same kind of pattern plays out in pharmacy, it plays out in allied health professional disciplines, and mental health disciplines, and other disciplines. So this is not just an issue having to do with physician capacity, it's an issue having to do with the capacity of the entire health system. And what I would encourage you to do is to really look at the entire system, because in healthcare, everything is connected to everything else. And it isn't sufficient to just look at physician supply, as Senator Balfour said. We've got to look at who is qualified to provide which services How many of them are we preparing? Are we placing them into the areas of need? Is the funding or the incentives set up in a way to encourage them to go into positions of greatest need? Are we working collaboratively between higher education, the practice community, the hospital community, government, our licensing boards, our professional societies? Do we in fact have a health professional workforce plan that is in some way linked to our best understanding of the current and projected health needs of the population that we're all here to serve? Now that sounds pretty simple, but it is extremely complicated. And when you pull on one lever, you cause ramifications that move, throughout the system in a variety of ways, some of which are predictable and some of which aren't. So it really is important, I believe, for the legislature to assert that the health of the population is a very important role. And it's an important issue to be cognizant of and to pay attention to. And to engage all parties in working collaboratively on the best potential solutions. We in higher education have our responsibilities, to be sure. Our professional societies and associations have their responsibilities, but everybody has a stake in this. How we fund health professional education, how we fund the individuals to be incented to take faculty roles, how we pay for our health care, how we leverage information technology, what we do to promote the spread of those kinds of innovations that will enable us to extend our capacity of our system as far as possible. A whole variety of issues need to be thought through, and we need to stay at the task, because this is not a short-term issue. The issues involving the capacity of our health system are issues that are structural in nature. They have to do with the way our health system is designed, and they have to do with our population and what we expect to be happening with the population as we look down the road. It's not a short-term issue, and unless we plan to outsource our health professional education internationally over the long term, we're going to have to really take responsibility for it. So I don't really have any solutions to offer today. What I can tell you is that the university system is going to work at the level of the system to assure that what we're doing is leveraging our assets as well as possible in a coordinated way, working in concert with DTAE to try to expand our capacity and increase the capacity across all the health professions as quickly and as rapidly as we can. And I'll be happy to answer any questions.
Chair Lady Cooper.
Dr. Ron, when you're talking about it, the problems being across disciplines and all, is that an example of the fact that Kennesaw State last year turned away 9 qualified students that wanted to go into nursing and took 1, and they said it was because of not enough faculty members and because they needed a new nursing building and just lack of space to take them?
I won't speak to the facilities issues, but let me just, our information, best available information within the university system is that at this time we don't have a pipeline program. We don't have a pipeline problem. We have adequate qualified applicants. We don't have adequate diversity among those applicants, but we have adequate qualified applicants. In nursing, there were excess applicants for all programs who by the admissions committee were deemed to be qualified to be enrolled as students. There's a 20-to-1 ratio that's a requirement for program accreditation, students to faculty. So the number of faculty is really the limiting factor there. There are 513 faculty in nursing schools across the system. In a survey done in April, there were 55 vacancies across the system. And that was expected. There were 19 additional retirements expected. So in nursing in particular, faculty capacity seems to be the primary limitation. The secondary limitation is clinical placements. Do we have adequate clinical placements for the clinical components of the training? The facilities issues are probably number 3. So that is an issue.
Representative Lunsford.
No, sir. Not a conversation.
Okay. Senator Hill, Judson Hill.
Thank you, Mr. Chairman. Thank you, Mr. Chairman. Doctor, I've got a couple of questions. One is, if you factor in the national population growth over the last 25 years, where are we at the national level? Do we have more physicians per 100,000? Do we have less?
Well, I believe that Dr. Salzberg data includes that somewhere. We right now, go ahead, Ed, nationally.
We do have more physicians now nationally, and we will continue to grow for the next decade.
Per 100,000?
Per 100,000, although the growth per 100,000 is very slow at this point. But we are still growing, yes.
So is it a Georgia issue on the physicians are not coming to Georgia versus other states? You know, you look at some of these graphs and you look at the small states, obviously, like Massachusetts can have more per 100,000 maybe.
Well, again, I mean, Ben may have some ideas about this as well, but our medical student to population ratio is in the mid-30s for the states. Our physician to population ratio is up this year, up in 2004 for the first time, and it has been below the national average. Our residency slots per population is in the mid-30s as well. So we're a net importer structurally for our system. Based on the state's growth, we have to be a net importer. And we will be even if we increase our numbers by 25%, we would have to increase our residency positions really dramatically. I'm not aware of exodus from the state. In fact, last year was a very good year, 1,000 new licenses issued. And I don't know, Ben, do you know how many of those are from outside Georgia?
No.
Okay, so I don't know the answer to that. Yes, sir.
And a follow-up, you've also said it's the way the health system is designed that really is one of the key influencers. You have 2 or 3 suggestions, recommendations, solutions. You said you weren't offering those, but maybe factors that are impacting that in your opinion?
What I meant to say is that the capacity of our health system to meet the health needs of the population is not just a manifestation of the numbers of professionals. You know, it's also a result of scope of practice issues, teamwork, our ability to leverage information technology. The United States is generally deemed to be significantly behind most of the rest of the Western world in terms of the entry of information technology and its use in healthcare. That there are just lots of different moving parts that interact with each other that impact on our capacity. And so I don't think we can look at individual issues in isolation. What Dr. Salzberg said, though, is absolutely true, that as one looks at advances over time, no advances to date have reduced our dependency on the numbers of health professionals across the whole board.
One more question, Senator Balfour.
The question was brought up earlier about nursing, and I think you mentioned 3 things: teachers, clinical, and facilities were the 3 items about filling nursing slots. I was sitting down with Gwinnett Tech just the other day. I brought up teachers because that's what I keep on hearing. They're telling me they have plenty of teachers. They have 2 hospitals in Gwinnett County who are looking for clinical nurses in there and plenty of slots. They have the facilities, but the nursing board continually turns them down for approval.
And the question is?
Well, I mean, if those are the 3 things needed and we have them all taken care of and we have a nursing shortage, what is the nursing board doing turning down a group that has all the supplies ready to put nurses into the system, but a nursing board is turning them down?
Well, Senator Balfour, I'm not a spokesperson for the nursing board. What I can speak to is the university system. We have 28 different programs in the university system, not DTAE. 28 different programs. They have geographic dispersion, and their limitation is 55 faculty vacancies. It's not for us, it's not the number of programs. And for us, it's developing faculty and retaining faculty in practice roles. Gwinnett Tech may be in a totally different circumstance.
Dr. Ryan, thank you very much. Maybe I'll go back and get a part-time faculty position to supplement my income from being a legislator. So we need to move on.
Good.
Okay, Dr.
Dr.
Thomas.
Robinson, you introduce the next speaker.
Oh, he didn't know. Is he different?
I think that's it.
I don't think he knew him, but I guess he knows him.
Yeah.
Okay.
Again, to be quick, the next person is Dr. Jim Mcnatt. He is with the Composite State Board of Medical Examiners, and so he obviously lives a lot of these issues we're talking about on a daily basis. And so, without any further ado, Dr. Mcnatt.
Thank you. I appreciate the opportunity to be here. I think my main purpose in being here is to be held accountable for the recent legislative initiatives, and I was going to update you on what the medical board has done in those areas. I wanted to start off basically with a brief overview of the state medical board. It's an independent agency administratively attached to the Department of Community Health. There are 13 members from across the state who serve. They receive a per diem, and they do an incredible job of carrying out the work of the medical board. The executive director, LaShawn Hughes, reports directly to the board, and the rest of the staff, including me, report to her. The board usually meets 2 days a month. There's a 30-member staff, of whom 7 are investigators, and we have about a $2 million a year budget. We currently license and regulate over 32,000 healthcare professionals, including mainly physicians, but also PAs and respiratory care professionals, et cetera. Regarding the earlier issue of how many ancillary personnel there are to provide health care in Georgia, the number of physician's assistants that are present or licensed by the board are about 2,500. And I believe that the number of nurses that we expect to receive nurse protocols from their physicians from is about 4,000 or so. So if you add the total, that's only about 6,500 additional people. So I don't think that number is going to dramatically alter the delivery of health care. The medical board itself handles between 1,600 and 2,000 complaints a year, and that definitely keeps us busy. We also process over 2,000 applications a year. Most of those are physicians. Balancing that, as we've heard earlier, the new applications for physicians is the people every 2 years that don't renew their licenses. So there has been a small increase in the number of doctors that are currently licensed. The 400-pound gorilla in the room regarding this current or the last session legislation is Senate Bill 480, which is a nurse prescribing bill. It became law upon the governor's signature and was effective on July 1st of 2006. I made promises to several people that the medical board would have those nurse protocol rules up and running as soon as possible. And the proposed board rules are now out on the internet, and we're now receiving quite a few comments. The review hearing itself will be held at 2 Peachtree Street on September 14th, and we expect a standing room only crowd. Basically, the bill allows advanced practice registered nurses to prescribe drugs and medical procedures pursuant to a nurse protocol submitted by their physician and approved by the board. Some of the proposed nurse protocol considerations are that, in no particular order here, is that nurse practitioners will be able to prescribe controlled substances schedules 3 through 5 only with a personal DEA registration, and the DEA still has not responded, as far as I know at this point, to when that registration will be available to advanced practice nurses in Georgia. They are not able to prescribe either Schedule 1 or Schedule 2 substances. Another issue is that the law and the rules require that the physician be licensed in Georgia, the supervising physician be licensed in Georgia, or that the principal place of residence, if it's out or practice, if it's outside of Georgia, must be within 50 miles of where the nurse protocol is being utilized. The law requires that physicians personally evaluate patients seen by nurse practitioners and who are receiving controlled substances at least every 3 months. And in addition, the rules as currently proposed by the medical board require that any patients receiving prescriptions of any kind be evaluated by a physician every 6 months. Moving on to that, and I'm sure there'll be some questions about that at the end. Another law that was passed and effective on July 1st was the physician's assistant handling of drug samples. Basically, we have added a duty to the basic job description of physician's assistants that allows them to receive and distribute pharmaceuticals, including samples, as an additional duty. And there are some additional rules that are under consideration by the Attorney General's office. I might add that the nurse protocol rules have been carefully created with the assistance of the Attorney General's office also. There were several scope of practice bills that came before the legislature this past session, including the optometrist, the psychologist, and the chiropractor bills, and none of those passed this session, but I'm sure that that we will hear more on that. And the medical board is interested in this, and I'll be available to respond to any questions regarding the medical board's input on this. I think their interest is primarily that most of the duties that we're talking about here are under current law are the practice of medicine and currently under the jurisdiction of the medical board. The electronic prescription drug law was actually passed a couple of years ago in its basic form and has, I think, since been modified. After a number of attempts, the electronic prescription drug rules have finally reached a final hearing, and they were adopted on August 16th, and I think that's going to be a great boon for doctors and patients in the state to be able to prescribe electronically. Is going to, I think, provide some additional patient safety. Schedule 2 controlled substances are not included in the bill or in the rules, and will not be until the feds decide that that's a possibility. Right now, Schedule 2 controlled substances still require a handwritten signature. Another area that's out there that I'm sure you all have had some feedback on or some interest in is the whole area of who can use lasers to perform treatments on humans. This is actually a difficult area that a number of states have addressed with varying success. We have rules that the medical board has worked on a couple of times. We've had a hearing already, and based on the input at that hearing, the rules were held back, and they've been revamped and are now at the Attorney General's office for further review before being posted. And we anticipate a hearing on laser rules probably in either October or November. Basically, lasers, or the medical board's understanding of this, is that lasers are FDA Class 2 devices. They're Class 2 prescriptive devices that can only be sold to a licensed practitioner with prescriptive authority. That includes physicians, veterinarians, dentists, and podiatrists, I think. There may be one more. And the medical board's position is that the use of lasers on patients is the practice of medicine. We have had various cases involving laser use, but we've never had any definitive rules to point to, so I think this will be a great service to both providers and patients when they are finally adopted. So the question then is, who can use lasers to treat patients? And currently, the answer is that licensed physicians can do so, PAs with additional duties under a basic job description, or advanced practice registered nurses under an approved protocol, and also qualified personnel such as a medical assistant under direct physician supervision. I wanted to add a one slide here in board legislative initiatives. If you try to go through the Medical Practice Act, which I'm sure many of you all have, trying to wade through it is very difficult, and we're hoping, if not this session, at least the next session, to introduce some housekeeping amendments regarding the Medical Practice Act. We want to remove outdated language, license types, exams and approvals. We also want to remove examiners from the name because we don't do exams anymore, basically. And another issue that has come up is that we need a process for removing ineffective board members from the board. That could be by reason of people not attending, by having, legal issues before them, or whatever. All right, well, that's the end of my formal presentation. I'll be glad to respond to any questions, and if you have concerns that you would like me to take back to the medical board, I will certainly be happy to do that. Thank you.
First of all, Dr. Mcnatt, I'd like to thank you for promptly putting out proposed rules for the APRNs. I know that there was a major complaint that past boards had been charged with writing rules and regs and had not done so, so I feel like there's been a major change at the board, and you are moving toward that and putting regulations forward, so I appreciate that. Representative Drenner.
Dr. Mcnatt, just a quick question. I'm curious, are there specific rules on who's qualified to do cosmetic surgery?
No, cosmetic surgery does not have specific rules in Georgia. No laws or rules. I think they have those in place in Florida and some other states.
Representative Parson.
I want to ask a question. I just don't have any idea what the answer is. On the use of lasers, would a physician who didn't have any training in the use of lasers, would that physician have to have some kind of training?
Yes, under the proposed rules, he would require certain minimum training.
But then if he caused some kind of damage, it probably would be some other kind of specialist would have to treat that.
Yes and no. A lot of the physicians that use lasers are dermatologists, and they would be in the position to treat some of their own problems.
Thank you.
Representative Henson.
With regard to laser, bleaching of teeth in a dental office, the Bright Smile concept, which is laser, is that being addressed at all? Because right now the hygienists do it, not the dentist.
There is an exclusion for anybody that's not diagnosing and treating within the practice of medicine, so the practice of dentistry is not covered by the medical board, and we don't address that at all. That's one of the, I didn't go into the rules in that depth, but specifically anybody who is licensed by the state and able to perform laser surgery would be exempt from the medical board's jurisdiction.
Representative Kidd.
I wanted to get over to SB 480, if I could, please. When you, I'm looking at the fourth bullet on the first page, when it says allows advanced practice registered nurses to prescribe drugs and medical treatments pursuant to a nurse protocol approved by the board. I thought the law actually says that the board has the authority to pass a rule requiring that doctors submit their agreements for review, but not for approval. Has that changed, or how does that play with the wording in the law?
I would have to look at that more specifically. The intent and the understanding of the board is that the physician is required under the rule to submit the nurse protocol to the board for review. And pending that review, that the protocol is in place, and the medical board has the right, upon review of that protocol, to ask that physician to revise the protocol. Does that help any?
Provide changes or?
Provide changes in the protocol, right. I'd say if you were going to, just as an, if the protocol did not seem to be in line with what was the safe practice of medicine, then the medical board would have the ability to require a change in that protocol.
So the doctor would actually make the change. It would not be the board.
Right. The board would not make the changes. They could require the change be made, and the medical board does not have jurisdiction over the advanced practice nurses at all. That's the province of the nursing board. So our jurisdiction would be in giving the physician feedback on what an acceptable protocol would be.
Thank you very much, Dr. Mcnatt.
Thank you.
Thank you.
I think this is the last one. I think everybody appreciates your patience. Next is Mr. Rob Brosher. He's the Executive Director of the Division of Health Planning in the Department of Community Health, where they've been working a lot on the Certificate of Need issues that have been raised recently, and he's going to provide, I believe, a brief update on that.
While Mr. Brosher comes, I do want to thank the committee again and also our audience for allowing us to cover so many subjects, but it is hard for us to get together. Members have traveled from across the state, from almost to Florida, and so we thought we would try to get as much of an update as we possibly can. Rob, thank you very much for coming, and Dr. Mcnatt and all the other people that have presented.
Thank you. I'm Robert Brosher. I'm the Executive Director of the Division of Health Planning for the Department of Community Health. As most of you are aware, the legislature has established a Certificate of Need Study Commission, the Commission on the Efficacy of the Certificate of Need program. And I must say, Dr. Ron is the chair of that commission. I feel like I'm talking, well, I'm not behind his back, but I'm talking about him and he's here. So it's a bit awkward, but I'm sure you'll correct me if I get anything wrong, Dr. Ron.
Awkward's not the word.
Senator Balfour also serves on that commission, so I'm sure if I get anything wrong, he'll correct me as well. In your packet, there's a list of the members who serve on the CON Commission. The first commission meeting, and what I intend to do is just give you an overview of where the commission has been, where it is now, and where it's going in terms of time frame and its agenda. The commission first met in July of 2005, so they've been meeting about a year. And up till about April of this year, what they had been spending much of their time doing is getting presentations from stakeholders in the healthcare industry, such as the Georgia Hospital Association, the Medical Association of Georgia, the Nursing Home Association, individual physician groups, teaching hospitals, and those sort of institutions that may be affected by Certificate of Need, so that they could get some feel on what the healthcare market looks like before they make recommendations. So they spent a lot of time doing that, and then January of this year they issued some consensus points. So up to the half-year point, they had reached certain consensus points that they all agreed to. And the first of those was that rather than recommending the complete abolition of the Certificate of Need program, they'd be more apt to recommend certain changes to the Certificate of Need laws. And what those changes are still under discussion. But some of the other consensus points would be that quality should play some sort of role in Certificate of Need, that the department the statute should give the department certain authority to implement sanctions for those entities that violate Certificate of Need and do not submit data to the department so that it can appropriately issue certificates of need. That the appeals process, I've run Senator Balfour out talking about the CON Commission. The appeals process for Certificate of Need is lengthy and rarely results in any changes to the initial decision to issue or deny a Certificate of Need. So that was something they were concerned about. And finally, that cross-subsidization in healthcare significantly impacts any recommendations and makes the work of the CON Commission much more difficult in terms of recommending any changes, because cross-subsidization really impacts all the facilities that are affected by certificate of need, and getting rid of or making changes to certificate of need would significantly impact financing of those organizations. So that's where the Commission had been up to the beginning of this year, and then the Commission met after it had all of these stakeholder presentations and decided that it would create a work plan for the rest of the year and decide to engage a consultant. And so it put out an RFP to engage a consultant, and it received 2 responses, one from the Georgia State University Health Policy Center and one from Navigant Consulting, which is a private firm. It selected Georgia State University Health Policy Center as its consultant. Before it decided to put out an RFP, there was concern that it would be difficult to obtain a consultant because many individuals already out there who could potentially serve as a consultant have made up their mind about certificate of need, or they've made it clear what their position on certificate of need is. But what the CON Commission did in its RFP is say that it would receive no recommendations from the consultant, just data. The consultant would obtain data, access data, quality data, financial data from certain states and compare that to Georgia, but that the CON Commission itself would make any recommendations. The consultant would make none. So the consultant chosen again was the Georgia State University Health Policy Center. Also in April, the Commission decided to break itself up into subcommittees. There's a document in your packet called the Organization and Process of the CON Commission. And on page 3 of that document, I'm sorry it's hard to read, it's in black and white, there are 4 subcommittees that the CON Commission broke up into in order to continue its evaluation process and to make initial recommendations. And there are the Acute Care Committee, which would focus on acute care issues. The Long-Term Care Committee obviously would focus on long-term care issues. There's a committee called the Special and Other Services, which would focus on ambulatory surgery, which is a substantial issue that the CON Commission has been discussing, the differences between hospitals and physicians in regards to ambulatory surgery centers and the certificate of need process. And the final committee is a Legal and Regulatory Committee that would focus on legal and regulatory issues, such as the CON review process, the appeals process, and what is exempt from obtaining a certificate of need. That's the committee that would focus on those issues. So since that time, those subcommittees have been meeting, but they are waiting on obtaining data from the consultant. And the consultant is under a very tight time frame. They were selected in July, and they need to have data from 10 states to us by the end of September, of course in a comprehensible fashion, preferably. They have selected 10 states, and that's in your the second handout, third handout in your packet, called the Effect of Certificate of Need. Laws on healthcare delivery, and this was actually a presentation given by the consultant to the CON Commission. On page 5, they list the states they have chosen to compare Georgia with. Those 5 states are 10 states, are Maine, West Virginia, Washington, Iowa, Florida, Massachusetts, Wisconsin, Oregon, Colorado, and Utah. And the reason they selected those states is, first of all, they have a very short time frame, and those states all submit data to the federal government. They participate in a program where they freely give health care data to the federal government, so it's in a centralized source. That was one of their reasons. The other reasons are they were looking for states that have no CON program, states that have a CON program but not as detailed as Georgia's or comprehensive as Georgia's CON program, and then states that were the same type of regulation as Georgia in terms of CON. They had a very robust CON program. So the states here, they're listed the number of services that are covered by CON, and a rank is where they've given them a rank based on the detail of CON regulations and the statutes and how many services are covered. And they've picked states that are as regulated as Georgia, some that are less regulated, and some that have no CON regulation at all. So that data is due to the Commission on by September 30th. what is the commission going to do with that data? The commission is going to review that data and come up with its final recommendations in its subcommittees before it intends to do so before the end of the year, so that it'll be ready for the next legislative session. Of course, that's a very tight time frame, and so what's in your packet is some set meeting dates and some possible meeting dates of the commission and the subcommittees of the commission so that they complete their work. And again, it is their intent to have some final recommendations before the next legislative session. If by chance they've discussed a backup plan, if they're not finished by the next legislative session, they will have some recommendations, because there are some things that can be easily agreed upon and consensus can be reached upon. And then statutorily, they're not abolished until July of 2007, so they would continue their work. But they would have some initial recommendations before the next legislative session.
Okay. Thank you, Rob. I mean, I think I've been attending as many of the CON meetings as I can make. I have one question that came up because of something you said, Rob, but before Mr. Salzberg leaves. One of the groups that has been testifying has been the general surgeons, and wanting to be recognized as a specialty, which we do not recognize them as a specialty in Georgia. I think, Mr. Salzberg, you said that general surgeons are decreasing across the country, and these are the guys who do the gallbladders and the trauma surgery and take care of you when you're in a car wreck and have abdominal, need your spleen worked on, and yet across the country they are decreasing. Is there a...
I didn't comment directly on that, but the numbers have been very stable for the last decade. General surgeons.
Did someone suggest that they were...
In this state, the per capita number of general surgeons is declining, although their overall numbers they've never been this high. They're just not growing as fast as the other specialties.
Which does have effect on any trauma centers that we have.
I can imagine.
Correct? Okay, but that has been one of the biggest groups in discussion, hasn't it, during the CON?
Yes, they're constantly writing comments to the CON Commission, and they've made 2 presentations, I believe, to the CON Commission. And that is one of the focus areas of the Special and Other Services Subcommittee, and that is an issue that is somewhat data-driven. They were given the same presentation that Mr. Robinson gave you was given to the CON Commission at their meeting last week. So they are taking that into consideration as well.
And for the committee, when you talk about how funding is, which is a concern to our teaching hospitals, which Dr. Ron's brought up right now, we're talking about when the hospitals say they don't get paid for indigent patients, so therefore they charge paying patients more money and they cost shift and so forth. This is what you're talking about.
And I'm talking about the cross-subsidization that the state has set up, where it pays more for certain services such as ambulatory surgery services and imaging services, for example, and less for other inpatient hospital care services. Pays below cost, but pays above cost for services such as ambulatory surgery and imaging.
What other questions by the committee? Okay, Dr. Ron.
I'll just make one comment.
Sir.
As Chair of the Commission, I just would like the committee to know that Mr. Brosher and all of the staff and the Division of Health Planning of the Department of Community Health have taken on the responsibilities of staffing the work of the CON Commission in addition to all regular responsibilities. They have done an extraordinary duty now over more than a year, and as a state agency, they've just done a great job of supporting the work of the Commission.
Thank you, Dr. Ron. I think sometimes we forget to say thank you to our state agencies for the work that they do. Thank you. Are there any questions from the committee? I'm going to close it up.
Thank you.
Yes, been a very well-attended meeting, and we certainly appreciate our speakers being here and providing this information, and certainly all the audience being here. And it's a tremendous turnout of our committee members, and I think the show's so good we may take it on the road.
Thank you very much, everybody. We are adjourned.